Good morning. I'm Guy McKee, Associate Professor of Presidential Studies at the Miller Center of Public Affairs here at UVA. I'd like to welcome everyone to today's webinar on the Biden administration and the COVID-19 crisis. This is, of course, the most pressing issue facing the nation and the world as Joe Biden begins his presidency. And today, we will explore what the change in administrations means for the United States' approach to COVID-19 and what we can expect in the coming months. To help us do that, we have two outstanding panelists with us today. First, we have J. Stephen Morrison, who is Senior Vice President at the Center for Strategic and International Studies and Director of its Global Health Policy Center. As of today, he is also the James R. Schlesinger Distinguished Professor at the Miller Center. So it's my pleasure to welcome him not only to our panel, but publicly to the Miller Center as well. We're thrilled to have him join us. Dr. Morrison has directed several high-level commissions and is a frequent commentator on U.S. foreign policy, global health, Africa, and foreign assistance. He served in the Clinton administration as committee staff in the House of Representatives and taught for 12 years at the Johns Hopkins School of Advanced International Studies. He holds a PhD in political science from the University of Wisconsin and is a magna cum laude graduate of Yale College. Next, Margaret Foster Riley is professor of law, public health sciences, and public policy at the University of Virginia, where she teaches courses on food and drug law, health law, animal law, bioethics, regulation of clinical research, and public health law. She has written and presented extensively about healthcare law, biomedical research, genetics, reproductive technologies, stem cell research, animal biotechnology, health disparities, and chronic disease. She serves as the chair of UVA's Embryonic Stem Cell Research Oversight Committee and as legal advisor to the Health Sciences Institutional Review Board, which is responsible for reviewing all human subject research at UVA involving medically invasive procedures. She served on the National Research Council Committee on Revisions to the Common Rule for the Protection of Human Subjects, and she has advised numerous committees of the Institute of Medicine and the Virginia Bar. Before we begin, just a few technical matters. First, I want to thank the George and Judy Marcus Democracy Praxis Fund for its generous support of today's event. Also, throughout the event today, we invite the audience, you the audience members, to submit questions for our panelists throughout the program using the question and answer function at the bottom of your Zoom screen. We'll get to as many of the questions as we can through the program. Along the way, we'll also have a few audience poll questions as well. The panelists and I thought that the best way to begin this morning is with a brief overview of the current status of the pandemic. If we could have the first slide, please. Okay, so here we see a number of measures of the trajectory of the COVID-19 pandemic in the United States since last April, essentially the start of the pandemic. We see, of course, the increase in daily cases, the summer rise, which we all thought was terrible until we got to this fall, when beginning in, I guess it was about October, we saw the really astronomical rise in cases with surges following Thanksgiving and then the Christmas, New Year's holidays, which you can clearly see reflected in that second chart of daily cases. Notably, there's a little bit of a decline over the last week or so in the 7-day average. This is positive news, and we can talk about that, but there's quite a bit of uncertainty as to what that really means, and whether this is really just a reprieve or if it's a potential long-term improvement. We can discuss some of those factors as we move. And of course, another dimension is hospitalization. You see that in the third metric, and then the fourth, daily deaths. Hospitalizations have only just begun to turn down. And if we can move to the second slide, which is one of our grimmer ones, what we see is that daily deaths on the 7-day average generally track hospitalizations by a relatively brief period of time, so that we are really still in the midst of that holiday surge in terms of the human costs of the pandemic. Also like to turn then to the third slide, which gives us a little bit of a sense of how the United States has done against other countries around the world. I'm sure many of you are familiar with this, but it's still really stunning, I think, to see this graphic and that light green line just immensely higher. And this is, of course, absolute, not relative numbers, but nonetheless, the American performance over the last year is really something I think we can all agree has been disappointing or really shameful, for lack of a better term. Another dimension that we should note with all of these measures is that there's a significant degree of inequity across lines of race and ethnicity in particular, and that African Americans and other minorities have quite simply suffered more than other Americans through the pandemic. And that's something that we are starting to see emerging in the ongoing vaccination campaign as well. We can discuss that and should discuss that more as we go. I would note, of course, that the vaccination campaign is underway. We have distributed just over 17.5 million vaccinations to approximately 15 million unique individuals, with over 2.4 million receiving now a second dose. And so I think that really sets up the conversation for today and some of the dimensions that we'll explore. And with that, I'm going to open it to our panelists for the first sort of general issue to discuss, and that is the start of the Biden administration. What does it mean for the US management of the pandemic, and what are the administration's priorities in this area? Margaret, you want to kick us off?
So you'll hear different versions of this. One is that the Biden administration is starting from scratch. The other is that the Biden administration is relying on some of the infrastructure and pieces that were put in place with the prior administration. And the truth is probably a little bit of both. What you're seeing is that this is the top priority of the administration. And if you have listened to the press briefing yesterday, and which featured Dr. Fauci, you can see that in place. There is now a COVID task force that is put together. Along with that is also a COVID equity force. And that's actually a really important piece of this, because one thing we weren't able to put in the graphs is how inequitable this virus has been in terms of the people who have been affected. So the very first priority for the Biden administration is to get the vaccines out. And you have probably heard that the plan is in the first 100 days, you have 100 million people who are served by the vaccine. And that is both an ambitious plan and and probably an undersell plan. If we can meet 1 million doses a day, we'll meet that easily. And a lot of that will depend on other issues that the administration is putting into force. One being using the Defense Production Act to ramp up supply and other types of pieces, using FEMA and the National Guard to help drive the ability to inoculate people. I would say one of the biggest gaps that has existed is we knew we had to create the vaccine and we knew we had to deliver it to the states, but the infrastructure for the states and the guidance from the federal government from the state to the states on how to get the vaccine into arms has been lacking. And so that has been a priority of the administration as it is proceeding. And there's a strategic plan that was published yesterday, actually, and that strategic plan really is, to me, remarkable in the way that it sets out how the administration plans to accomplish these goals.
Steve?
Sure, thank you so much. I mean, we've had several dramatic steps taken in the last few days. There was the American Rescue Plan that came out before the inauguration, $1.9 trillion request, of which $400 billion was to be contributed towards the pandemic response. We then had on the day of the inauguration, 3 executive orders. We can go into those details. Yesterday, we had an additional 10 executive orders and 3 presidential memoranda, all focused on the pandemic response. Professor Riley's touched on many of the key elements there. I think if we look at that whole sway of things, it's been developed intensively over a 6-month period by a team that was first assembled back in April, but then really got into gear in the July timeframe. It's a dramatic and strategic approach. It's sweeping in the scope. It's really an FDR style mobilization. It's been described by the president as a wartime undertaking. It promises if it is carried forward, and that requires a lot of money and concurrence from Congress, it will significantly change the place of public health and public health infrastructure and health security within America. The team is already in place to a significant degree. We have Tony Fauci carried over as the chief advisor to the president. We have Jeff Zients installed as a czar coordinator. Beth Cameron back into the White House, the newly reestablished National Security Council Senior Directorate on Global Health Security and Biodefense. We have David Kessler back in as on the Operation Warp Speed as a chief medical advisor. We have a czar on vaccines, Bashara Chucher. We have a Professor Marcela Nunez-Smith installed as the head of this equity task force. So it's pretty amazing how fast they got into place and got all of these memoranda forward and executive orders. They honored the dead in a dramatic way, obviously, on the 19th with the ceremony at the reflecting pool in the Lincoln Memorial. It's a mixture of harsh realism and an appeal to unity and an appeal to the better angels of Americans and an appeal for some optimism. But the terms dark winter dominated the president's speech. And there was this theme that has come through over and over again that this is going to be very hard. It's going to stretch our patience. It's going to take longer than we anticipate to turn the corner and achieve something looking like herd immunity. We can talk more about what would that look like. Interestingly, also, the president made a very emphatic point in restoring U.S. international leadership and engagement, restoring ties to the World Health Organization, joining the COVAX International Facility, signaling in the plan that was released yesterday that there will be a national security directive signed out soon by the president detailing what the next international steps will be. There's an expectation there will be a senior envoy appointed to serve under Secretary Blinken at the Department of State. We can go into, there's a lot to discuss in this package here, but it is very, very dramatic. It's a shift out of the Trump years, building on some of the many achievements, the most notable being generating the development on an accelerated and unprecedented basis of the Pfizer and Moderna vaccines. But it was also, the Trump era was a catastrophe in many, many areas. This is a shift towards a centralized, federal, nationally led effort to get us out from underneath this raging pandemic that currently is uncontrolled. Thank you.
Thank you both. I want to take a question from the audience because it sets up, I think, an important topic to discuss next. That is about the Defense Production Act, what its relevance is here, and whether there's a shortage of production. I assume that means about vaccines. I'd like to touch on that, on exactly where we stand on the vaccine distribution effort, because I do think the challenges may be shifting perhaps, and I think the production question is becoming paramount. I'm curious as to both of your thoughts. Has the slow, somewhat troubled startup been predictable, or are they normal bumps in the road? And what should we look for over the coming weeks and months in terms of the vaccination campaign itself?
Margaret, you want to try that?
Sure, I'll start and you can finish, or at least start to finish. I think, first of all, the Defense Production Act bears a little bit of information for the audience, and that is that this is actually a 1950 piece of legislation that was designed to help the United States deal with emergencies, especially those that would involve national security. And a pandemic is a national security issue. And what it allows the government to do is to develop both private and public partnerships and use public money and private money in a way that, for example, allows priorities to be set. So if you had a private company with contracts that were set to occur next week, the federal government can come in with the DPA and say, no, you're going to do our project first. And actually, one thing to say before I start talking about the vaccine issue is the DPA applies to a lot of things within the pandemic. And one of the biggest surprises for me has been the fact that the DPA has not been used to develop better masking. We still, Senator Murray asked in February whether there were sufficient N95s. The answer was no, and we still don't have sufficient masking of really top quality. But in terms of the vaccine, I would say in many ways, there are some things that were completely predictable. The two vaccines that currently have emergency use authorizations, the Moderna vaccine and the Pfizer vaccine, are using technology that we've been developing over decades, but a platform that's new for vaccines. And the extra piece is they're also using ingredients that they are trying to source in the United States or the EU. And for decades, we've actually been sourcing ingredients and raw materials in Asia. And by creating these new supply chains, it is completely predictable that we would have issues in that context. I would say what should not have happened, and yet was clear in November when you started looking at the state plans, is that there was no plan that would get the vaccine from the supply point, and some of these require really difficult refrigeration and issues like that, and get them to that place into the arms. And in fact, the issues that we're going to have are going to be more severe over time. It's really quite easy to vaccinate healthcare workers. A lot of them work in hospital settings and therefore at the point of supply. A lot of them don't, and that's where we've had a lot of issues in terms of vaccinating even the first group of people that we've sought to vaccinate. And so some of the things that the Biden administration is now doing, using the DPA to deal with some of those supply issues, also putting into force FEMA, which is used to dealing on a national issue with getting supplies out to the people who actually need it in a way that is effective, streamlined, and directed to the actual people needed. I think these pieces are going to be crucial as the Biden administration moves out, developing community centers. We have vaccine deserts. The original plan was to use Walgreens and CVS. There are plenty of places in the country that are suffering desperately and don't have access to commercial pharmacies. So we have to develop those processes as well. And I'll let Steve go on because there's so much more, but let's hear from him.
Thank you. There's two questions that I heard. One on the use of the Defense Production Act, and the other about what do we make of the current chaos around the vaccination, the first phase of the vaccination. On the Defense Production Act, a couple of quick points, and to complement what we heard from Professor Riley. This was used very selectively, but very effectively by the Trump administration with a focus on ventilators. And we're hearing a lot less today about the shortage of ventilators. And you remember early back in the spring in the acute phase, then it was a really grave concern. And but there was a reluctance. And after mid-April, when the administration shifted away away from taking lead responsibility and pushed things out onto the states. It was very loath to use this, even though governors, mayors, members of Congress from both parties were appealing to the administration to do that. So what is happening here is that President Biden is saying this is an instrument that's going to be used as a way to assert national authority to meet the requirements of states and local public health jurisdictions to meet their critical requirements and relieve the burden to some degree from them, and bring the cost down, shape the marketplace and the pricing, and bring about predictable delivery. All of those problems that have confounded the response across this nation. So the first focus will be on the 11 items that are in the input list, and some of those are very familiar: gowns, gloves, simple protective gear, testing reagents. It'll include things for vaccines that are very important if they're in shortage, like glass vials, syringes, things of that kind. Now, on the question of whether they will be used for vaccine shortages, it's not clear. Jeff Zients, the newly appointed czar, in an recent interview, said that issue is on the table to invoke this and try to pressure and put new demands upon Pfizer and Moderna to up their production. But that is a tricky question for reasons that I think Professor Riley suggested. Right now, Moderna and Pfizer are falling woefully short of what they are obligated under their current contract to deliver. They're each delivering 4.3 million vaccines per week. It should be at 7.5 million if they're going to hit their target, which is enough for 100 million people as of March 1st and 200 million people by the end of July, by early July. Those are the key targets to keep in mind, and there's great anxiety and uncertainty about whether it will be able to meet those targets. But this is as Professor Riley said, this is a new technology. It has never been produced at scale. The manufacturing process is complicated. It is prone to problems. We shouldn't be too surprised that there are production problems. So invoking the Defense Production Act may not solve your problem. What they're talking about right now is trying to use that in order to bring about production of certain inputs that could help Pfizer and Moderna up their production. In other words, look at who produces what are called lipid nanoparticles, which are the little tiny fat that wraps around the genetic material in the messenger RNA vaccines. They're also looking at producing what are called space needles, which are the needles that can go into the Pfizer containers and extract an extra dose, moving from 5 to 6 doses to expand the dose base. So those things are happening. It is a reversal of the abdication of responsibility. It's the assumption of national federal responsibility. It marks a very dramatic change from Trump. Now, as far as what do we make of this current problem in our rollout of vaccines, I think it's fair to say that the first month was a deeply disappointing and confused and shocking moment. I think when the Biden team finally got in the door to have an honest conversation about what was going on, they realized there was no plan. There was no one in charge on the last mile. The vaccines under the Defense Department and its contractors delivered to 64 sites and 5 federal agencies. From that point forward, it was up to the states and localities to engineer this, and it was way beyond their capacities. It was a very complex logistical operation. It was one where it was disrupted by the holidays. It was coming at a period in which our health system has been stretched to the breaking point. We have enormous fatigue in our health providers. We have weak public health infrastructure in those 3,000 jurisdictions. The money had not flowed yet to those 3,000 jurisdictions to give them the wherewithal to hire the staff and pay for the logistical cost of distributions. There was no national communications plan to the public. So it was a disaster. What we are seeing right now is some sorting out of that. The vaccination levels are rising. We are up to just under 1 million per day. That is good news. that is good news. And I think mayors and governors and others have jumped in and with varying degrees of success have filled the void and found solutions that have been jerry-rigged in amidst all of this confusion. But don't underestimate the level of confusion today on the ground. Just read any commentary of what's going on around the country. So there is a huge task in front of the Biden administration in disentangling this and bringing some greater transparency and coordination and rationality in the planning and execution of all of this. And there's an acute awareness, and we've heard this from the president and others over and over again, that this is going to take some time to sort out. And to get back to the big picture, what that means is, when are we going to hit herd immunity in this country and pivot out of this pandemic and into something approaching normality? These sorts of delays and disruptions throw great uncertainty into that question, and we don't know. And of course, the new variants, which I think we may talk about, add another level of uncertainty. Thank you.
There's an audience question that is a nice follow-up that I want to ask in a moment. But before I do that, I want to take a quick audience poll. If we can pull that up, please. And once that comes up, there are two questions here. One goes back, I guess, to the overview of whether you personally know anyone who has died from COVID. And then secondly, will you get the vaccine as soon as it is available to you? Now, while audience members are answering that, and we gather the quick data, I'll take that audience question, because I think it's actually an interesting one, and one that I think people need to know the answer to. And this is, are there other companies capable of making vaccine who are not already doing so, and whether that could be subject to the DPA? I think that's an important question, actually, for people to understand, but maybe also an opening to some of the other things that are in the pipeline in terms of vaccines.
Margaret?
So there's actually quite a remarkable pipeline going on, and one could look at what's going on in the United States and also internationally. And I should say, in most instances, this is at least international in the context that we're talking about Europe and the US. So the vaccines that we already have emergency use authorizations in the United States, we have the two, Moderna and Pfizer. We are expecting to have a vaccine from J&J, likely, at least based on preliminary data, sometime at the end of March. And J&J is already ramping up considerably in that area. And so what we should expect with that, I think, is 100 million doses from J&J. Now, what's kind of remarkable about the J&J, it's not actually an mRNA platform, it's a different platform, but it only requires one dose. And so that should actually help the process considerably. What we don't know, of course, with the J&J vaccine yet, we don't have the phase 3 data, is that vaccine as effective as what we're seeing with Moderna and Pfizer? Then going down through the pipeline in phase 2 and 3, they're up to 10 already in full phase 2, moving into phase 3, which is the last stages of clinical trials. And then beyond that, quite a few more. We'll talk about some of this later, but one of the important pieces of some of the pipeline drugs is they are able to deal with the situation we currently have. And that is where we're starting to see variants in the virus, or as Dr. Fauci calls them, mutants, and how we deal with those mutants. What's very remarkable and important to me is that some of these pipeline drugs may be able to answer some of those issues, and we'll talk more about that later. But we are going to need every single vaccine that can be created. There are some major players like Sanofi who are big vaccine players who are likely to play a major role both nationally and internationally, and we need them out there. An issue we'll also talk about later is we are not fully protected unless there's global protection. And so these vaccines that are coming up and not yet ready, some of them in really preliminary stages, will be necessary. I don't know that the DPA is going to be necessary in terms of getting companies interested. There is, unlike most vaccine situations, this is a situation where vaccines are actually profitable for companies. And so they're actually very willing to enter this sector. But for them to have the raw materials, all the other pieces that would be important in delivering the vaccine, that we may need the DPA to help with.
Thanks. A couple of points to add to what Margaret just said. Keep in mind the program of developing the 6 lead candidates by the US in its portfolio that Margaret reviewed. That was undertaken under Operation Warp Speed with $14.5 billion of capital in order to motivate. They basically took away the development costs. They took away the manufacturing and production costs by agreeing to pay at risk for these companies to go build the factories and begin the production even before they'd gotten through phase 3 trials. And that's an extraordinary undertaking. A similar thing is happening in China with the 5 vaccines in their phase 3 trials. I think there's a total of 18 or 19 in phase 3 trials. And in terms of the other candidates that are in some level of clinical exploration, it's well over 200 vaccine candidates globally today. So we are very lucky, I think, that when you look at the 18 that are in phase 3 trials or out of phase 3 trials and coming in like Pfizer and Moderna into emergency use authorization while the trials continue, we have a very diverse, in terms of the technical definition of the vaccines, we have a very diverse portfolio that looks very promising, from the more conventional to the experimental. And we've had astonishing results with the 94-95% efficacy and safety for Moderna and Pfizer. And you can't underestimate what a godsend that has been. And that was not preordained. This was something discovered. We discovered over the course of 2020 that we could accelerate the development of these messenger RNA vaccines in the midst of a dire pandemic in record speed. And that's an enormous thing to celebrate. And it's taught us a great deal. And you can imagine there will be a second and third generation of vaccines that come forward following this first lineup of candidates. Last point, I think we just need to remind everybody that there's still quite a bit of scientific uncertainty of vaccines. We don't know, even those that we're celebrating, the Pfizer and Moderna, that we're moving out and beginning to vaccinate Americans, and soon J&J will come online. We don't know exactly how long the immunity is that those vaccines will confer. How long will that last? Does it require revaccination every 1 year, 3 years, 5 years? We don't know the answer to that question. We have not done field trials for pregnant women and for children. So there are significant populations that we're going to have to do a scramble forward on the field trials for those populations. We also do not know if these vaccines are going to block onward transmission. And what I mean by that is, if you or I get a 2-dose vaccine from Pfizer or Moderna, and we're protected from, if we get infected, it will not advance to the disease form. We're protected, but we may, if we get infected, continue to pass that virus asymptomatically and unknowingly to other people. And that is another very complicating factor. So that even as our population that's getting vaccinated is growing and we're getting closer to herd immunity at a 75 or 80% level, we're still going to have to use all sorts of behavioral protections, masking, distancing, avoiding congregate settings, because those of us who are vaccinated may still be transmitters. Thank you.
Is my understanding correct that we're currently doing trials on populations like children in particular and pregnant women? So we should be getting
those are beginning. There's nothing abnormal about sequencing the trials in that fashion. And so they are accelerating. There was at the end of 2020, there was a major field trial out of Korea on children, which had some promising results. And NIH is moving forward fast forward on that front.
Let's bring the poll results back up. They probably flashed quickly. I think they're quite striking. Wow, number one, that's really something. That 36% of our audience knows somebody who has died. I think so it gives you an informal but striking measure of what we've dealt with over the last year. And then number two, that's reassuring. I applaud all of you. Take the vaccine as soon as you can. There's an interesting piece in the New York Times yesterday on some of the medical ethics, given some of the chaos, that you should take it as soon as it's available to you. So again, I applaud you for your willingness to take that. Please do. We've had a number of questions and a couple quick allusions to some of the new variants that have emerged. This is obviously a subject of great concern for all of us. What can you both tell us about the variants? What do we need to know what this means for the ongoing shape of the pandemic?
Steve, you want me to start again?
Yeah, sure. Please.
Is that our symbol? So what we know about variants, first is to say viruses mutate all the time, and we should expect viruses and RNA viruses, which the coronaviruses are, to mutate all the time. The question is it a mutation that has an impact? And impact is, do the things that we have in place to deal with the virus, or to try to start dealing with the virus, still have the efficacy that we hope they will have going forward? Now, first thing, it's worth repeating, it's just not repeated enough. Masks work on all viruses. The better the mask, the better it works, but it doesn't matter how many variants we get. Masks work, and social distancing works, and avoiding congregate settings work. And so that's something to put in place for people to remember from the very start. There are two main variants we're concerned about right now. One is the so-called UK variant. I should state that that's because UK has dramatically good testing and identified it early. We know from our own testing that it is likely already in at least 20 states in the United States. And to me, if you've got it in 20 states, you've got it in 50 states, most likely. And that variant is important because it seems to double the transmissibility of the virus. It doesn't seem to necessarily create a more virulent situation that is on its own more dangerous, but it's important to realize that if it's more transmissible, it's likely to build the number of hospitalizations that are out there, and hospitalizations lead to death. And so that's an issue we have to be very concerned about. Right now, it does seem that both the Pfizer and Moderna preliminary testing shows that the Pfizer and Moderna vaccines do seem to be active with that variant. The second variant is the so-called South African variant, and that one is more troubling. It is more troubling because it's structurally different enough that there seems to be an impact on a number of important factors. One being, you may all remember that one of the treatments that President Trump got when he tested positive was monoclonal antibodies. And that's one of our most important first-line treatments for COVID. And there's some evidence that monoclonal antibodies may not be as effective, or the ones we currently have may not be as effective with the South African variant. There's also some evidence that the vaccines may not be as active, and I'm using that word active very carefully, because that's not the same as efficacy. And what we think so far, based on the variant knowledge that we have, is that the efficacy may still be very, very good, maybe not 94%, but at 80%. And that some of that activity is built into the cushion that you have in terms of the activity of the vaccine against the virus, in terms of mounting the body's immune defense. So these are too worrisome. I'm worried more about, in the short term, about the so-called UK variant, because until we get people vaccinated, double the transmissibility is really bad news. And so that does mean that our next month could be very, very difficult. If you look at the charts that we showed in the very beginning, you saw hospitalizations coming down. With a more transmissible virus, you're more likely to see hospitalizations going up. And with more hospitalizations, you get more deaths. Long term, I'm more worried about the South African virus, but I actually do think that we have ways, as we discussed a little bit in terms of the pipeline for vaccines, and the fact that we're incredibly lucky that this mRNA platform is actually a platform that can be adjusted. And I think that what you'll see is the FDA will actually be able to, as it reviews any changes that might be done, it will be able to adjust the review process and speed the process along considerably. Steve?
A few remarks. What we've seen in South Africa and what we've seen in Britain has really rattled the world. There are alarm bells going off and enormous anxiety about what this means, both for vaccines and for therapies. We don't have a lot of good therapies to introduce, and there's been a lot of excitement around monoclonal antibodies and to some degree around convalescent plasma. Both of those are called into questions very significantly. Here in the United States, we've been flying blind. We have very, very limited genomic sequencing capacity in the United States, by contrast with Britain and elsewhere. So when Tony Fauci said we've got we've identified it in 20 states, there's 144 cases identified as of yesterday, and it's still officially only 0.5% of the cases in the United States, the new cases in the United States. The subtext was, we don't really know this. The reality is this thing moves like wildfire. And if you trace the progression within the UK over the fall, starting in the September to today, it's pretty unsettling. What are we going to do about this? Well, if you look at the American Rescue Plan that was released prior to inauguration, you look at the national strategy released yesterday, there's a big commitment to correcting that bald spot in our genomic infrastructure, surveillance infrastructure, and accelerate creating capacity, expand labs and surveillance on this. This will likely change the arc of the pandemic. If you get a 50% increase in transmissibility, that means that it's going to race out in front of your control devices in all of your interventions, and you're going to have more people infected, more people sick, and more people dying. And so it motivates, it gets people to sit up in their seats even more straight to think about, what do we have to do here in vaccinating people on a rushed basis to get ahead of this thing? And people are going back to the basics. They're going back to, we need behavior. We need to control this with the behavioral interventions that Margaret referenced. We need to accelerate the vaccination. We need to get visibility onto this with genomics. We may find that this bumps up the number that we have to inoculate in the United States to achieve herd immunity. Prior to this, people were saying, well, maybe it's a 70 or 75% of the population that we need to cover out of 328 million people, which would be somewhere in the 245 million people. And then you might back out some of the children and others who perhaps are not going to be in that first wave. But if you bump up to 85%, that adds an additional increment. And you're creating new velocity in this already highly pernicious and fast moving virus. One last point, which is people are now starting to ponder, and you see some reference to this in the national strategy, buried in the national strategy, reference to the fact that there's going to have to be accelerated R&D on how do we change Moderna and Pfizer messenger RNA vaccines. How are we going to change the J&J vaccine? If we have to make changes, how are we going to do that? What's going to be effective? And so you're going to see much more action driven by NIH and others in that, on that side of things. And as well, there's enormous concern about what can be done to preserve the integrity and effectiveness of the monoclonal antibodies and the convalescent plasma, which are two of the most important tools we have in stopping the progression of disease from moderate illness to severe illness, and to interrupt that and block that. So thank you.
Margaret mentioned the importance, continuing importance of masks. And I want to go to our next poll question now, if we can. And that is about Biden's proposed, or not proposed, I believe he's now issued it, the national mask mandate, and whether you believe a mask mandate would be effective. I would sort of add, this is of course with the messaging that the administration is putting behind it to convince people of the efficacy, the importance of this step. But given all that, what do you think? Is this effective or not? Somebody also asked what our response rate on the first set of polls was, and I'm happy to say our production team tells me it was 90%. So that's great. Please answer the question. Let's get that closer to 100.
Young, may I add one remark on this question around
Absolutely.
mandates? The president doesn't have the authority to impose a national mandate per se, but he's taken two actions so far. One has to do with the requirement of masking on federal properties, federal agencies, federal employees. And the second has to do with transport by all modes, interstate transport by all modes. And there's still ambiguity. How is this going to be applied in national parks and that sort of thing? But the broad impact upon Americans, about 76% of Americans are masking today, which is a number that's way up from earlier. There are certain states that have very low mask rates. But if we want to try and get from 75 to 85, 95, it's going to require persuasion of a public through presidential efforts and other efforts to get people to think differently and to bring down the noise and depoliticize and detoxify masks as an issue that have gotten caught in our culture wars and in the tensions, to get people to see them in a different light. So the communications and the engagement in this next phase, if we're going to go from 75 to 95, which I think is probably the target here, it's going to require quite intensive engagement.
I saw our results come up there briefly, and 86% of you say yes. So we'll take that as an endorsement of this as a moment of change and optimism amid all the challenges that we face. And
yeah.
There is something there. Any change in presidential administration is a new beginning, but I think especially in this case, and some of the factors that we just mentioned. We're down to about our last 10 minutes here, and I want to turn to the global dimensions of the crisis. We've touched on this in passing, but maybe we can look a little bit more directly at the global situation and how the Biden administration is shifting American priorities there. And I'm really interested here in what's at stake in the global vaccination effort, both in terms of the health implications, but also some of the global geopolitics that are involved in vaccine development, production, and distribution.
So
Steve, have you good? Or go ahead.
Yeah, I was going to suggest Steve is the expert here on some of the global strategy piece. So,
all right, I'm happy to say a few things. What's at stake right now? I mean, this is the year of the vaccine. Next year will be a year of vaccine, and there's enormous concern that we're going to head into a very bifurcated world in which the most wealthy and powerful countries, which have locked up stocks, there's about 14.5 billion doses that are in production, and the wealthiest, most powerful have locked up 85 or 90% of those dosages for their own sovereign purposes to meet the demands of their country's citizens. And there's a whole world of low and middle income countries which are living in a period of uncertainty and peril as to will they be left behind? What will the timeline be? How long will it take? What will the consequences be if we have a world in which there is the achievement of herd immunity in these rich places, but great delays? And what is that going to mean in terms of global control? But also, what does that mean in terms of equity and justice? So we've had a couple of things happen that are dramatic. There was the launch of it's called the ACT Accelerator, the tools for control of the pandemic, and within that is a facility for vaccines called the COVAX facility that has gotten up and running. It's trying to cover 20% of the requirement in the next 2 years of about 92 low and middle income countries. It's struggling. It's gotten greater resources in the mix, including a $4 billion US contribution that's coming into Gavi, which is the Vaccine Alliance, the major implementer that came through with bipartisan support in the last COVID emergency supplemental in December. So that's going on. The other thing that's happening is China it's beginning to strike deals. It's doing field trials in 16 countries. It's developing partnerships. It's developing supply arrangements for vaccines that have not yet officially passed muster in terms of the publication of phase 3 safety and efficacy. But they are moving ahead in inoculating their own citizens and beginning to inoculate in some of these settings. We have that happen. It's an aggressive form of diplomacy with vaccines. We have Russia doing something very similar without phase 3 trial results, breaking those norms. We have Bharat Institute in India has just been given emergency use authorization to begin use of its vaccine within India without phase 3 trials. So we are at risk of a world in which there are haves and have-nots. Desperate countries may opt for unsafe options, crappy vaccines that have not been put through the rigor that is required. We could wind up with a very mixed and dangerous sort of situation in the world. The US announced that it is restoring its relationship with WHO and joining COVAX. I mentioned earlier, there's $4 billion that have been put towards Gavi. So we have instant credibility and standing in that regard. And we have officially announced that we are joining the COVAX facility. That's a great thing. One of the big unanswered questions is what happens will there be large surplus stocks of these vaccines that can be redeployed towards the benefit of low and middle income countries? And if so, when might they become available and how might they be released? And what that presupposes is that the wealthy and most powerful reach a point of herd immunity and they begin to understand how much stockpiles they have to have in order to replenish. If they have to revaccinate once a year, they have to keep that stockpile. But if they get to a point where they feel like they have redundancy and they can begin to shift those surpluses over, how are they going to do that? And my sense is it's going to be a mixture of solidarity and multilateralism, putting stocks into a framework with the COVAX facility, and it's going to be a lot of bilateral deal making, rewarding your geopolitical allies. And I think you're going to see the EU doing that, the UK doing that, ourselves, the French and the Germans, as well as obviously the Chinese and the Russians. Thank you.
So I'm going to only add one last sort of crowning point on that, and that is to remember that viruses don't care about borders. They just don't. And one of the biggest failings that we had was this notion of containment, that we would be able to contain a virus that had epidemic and the later pandemic proportions. And if there's any lesson that we learn from this process, it should be this notion that there has to be some form of solidarity if we're going to avoid another pandemic.
Yeah, crucially important point on that. And one of the many things that hopefully we've learned as a society and a global community. We're almost at the end of the hour. I'd like to ask both of you for your closing thoughts, and maybe a way to structure that is what level of optimism you feel about the coming year at this moment of change.
Margaret?
So I'm an optimist, actually. That's partly personality, and we should always remember that. But I am an optimist in terms of 2021 and certainly into 2022. I am a pessimist when it comes to February and March. I think we are in for a whole lot of hurt. I would be stunned if we don't reach 500,000 deaths by the end of March, just based on the current trends and the fact that we have a more likely transmissible variant going on. So short term, I'd love to see the masking that the public, that this audience thinks we're going to achieve going on throughout the public. If we can achieve that sort of masking for the next month, we're actually in a place where the things I just said won't happen. But I'm an optimist, but I'm also realistic. Long term, though, I actually am very optimistic. I think that we do have the capacity to reach herd immunity. And I think that we also have the capacity to adjust to the variants as they come on. One of the really wonderful things about the mRNA platforms is those are actually going to be useful for flu vaccines going forward. We're going to be able to actually not just deal with coronaviruses, but what we actually thought was the bigger risk for a long time, which was pandemic flu. And these are important achievements, and we should celebrate these achievements. But the bottom line is we're all in this together. And so the only way it's actually going to work is if everyone wants it to work. And that means Congress has already given a lot of money, but Congress is going to have to give more money to make us reach these objectives. And we're going to have to continue in this world, which is really unpleasant. I wish I could, have friends over to dinner and things like that as well. But if we can behave ourselves, if we can really think about other people and ourselves, I think that by the end of the summer, we actually start thinking about something that feels sort of normal. And certainly by the fall, we could achieve that. But if we don't actually act that way in the next 2 months, we won't get there. And so that's a real lesson for us. If we can do it, if we agree to do it, we can do it.
Thank you. I think I'm with Margaret in terms of being innately an optimist by many of the developments we've seen. Having said that, on the pessimistic or realistic or cautious side, we are in a terrible period, and and it's not over. And we face a lot of uncertainties and unknowns scientifically and in terms of politics and behavior, which, as Margaret pointed out, behavior is absolutely essential, and we're a very, very divided country. And I'm not sure how quickly we can overcome our political pathologies to get that kind of behavioral compliance. What has happened in the last several days in terms of the U.S. approach is extremely welcome in my mind. Extremely ambitious, extremely promising, very carefully put together, long overdue. Tragically, we should have been doing these things a year ago, and we were not. But now we're in a position to do this. So let's move forward. Let's be optimistic. Let's be proactive, and let's do our best. In terms of Congress has generally been a pretty good force in this period. When you look at the supplementals, the emergency supplementals that were put forward, you can fault Congress at different times for delays. And there was a huge gap between, as measures, the 2 trillion ran out, many of those provisions in late July. It was not until December. We had to get through our electoral cycle. Let's hope that in this next period that the temperature comes down and the vision that's put forward, maybe it's not completely funded as requested, but at least there's goodwill and good faith in moving things forward. I'm optimistic also that we've moved out of our completely inward vision in the midst of these roiling crises to be able to think about the international. In the 1.9 trillion American Rescue Plan, there's 11 billion of additional resources to put towards the international response. I think that's a very good thing. Congress is capable of rising to this occasion, I believe. I think one thing to keep in mind as a marker of where we are going will be, where will we be in October as winter returns? If we have achieved a durable herd immunity by that point, we're not sure yet what defines herd immunity, but if we've achieved a durable herd immunity across this country, we will escape a return to a winter surge next winter. And that will be the marker of success in my mind. We may not do that. We may have to go through another terrible winter, perhaps not as scaled as astronomically as this winter, but still painful with lots of loss. But let's pray that doesn't happen. And let's set our sights on getting to the point by late summer, early fall, in which these means that we have at our disposal. We have had a miraculous period of good fortune and advantages in the advances that have come in our scientific community, our research and development community, extraordinary openness and transparency and cooperation across regulatory agencies, institutes, foundations, governments, and the like. And we now have the opportunity to really put those scientific gains into practice in order to beat this terrible pandemic and the economic catastrophe and social instability that it's created. Thank you.
Rising to the occasion, I think, summarizes so much of what we've said today, and what this moment requires. Thank you both. Thank you to both of our panelists, Steve and Mimi. This has been wonderful. I know I've learned a lot. I'm sure our audience has as well. So thank you for joining us today. Thank you to our audience members for your participation, your questions in response to the polls, for being with us. Thanks to our production team too for keeping things moving smoothly behind the scenes and making it easy for those of us on screen. Keep wearing your masks, keep resistance, stay safe, everybody. Goodbye.
Thanks so much, Ken. Thank you, Margaret.